Hello, and welcome to my presentation on my article evaluation and critique for advanced clinical social work practice at Florida Atlantic University. So the focus of research articles for me, I really wanted to find out more about the identification and treatment of men meeting criteria for borderline personality disorder, where they are, and how we can get them into treatment. The three articles that I chose, one evaluates an assessment tool for borderline personality disorder and if it is appropriate to be used with men. The second article is differences between men and women with borderline personality disorder. And this particular article has co-occurring antisocial personality disorder and their involvement in either mental health services or criminal justice system, if there is a difference between the two genders in terms of where they start out with these two diagnoses and the contact that they have with mental health professionals. And the last article that I'm going to be looking at are the unique experiences of men with borderline personality disorders. And what can we learn about that so that way we can identify it sooner and get them into treatment sooner. So the first article, like I said, is about measuring borderline personality disorder in men. And the name of the article is Investigating Gender-Based Differential Item Functioning on the McLean Screening Instrument for Borderline Personality Disorder, otherwise known as the MSI-BPD. And so the article itself, the way that it is structured, let's go to that. The research questions is to determine if there is a measurement bias in items on the MSI BPD that do not reflect actual gender differences between men and women. Does the McLean Screening Inventory BPD provide information about BPD severity? Was one of the questions asked in this article. Do certain items on the screening provide more information about the diagnosis than others? Can gender bias be detected in the screening instrument? And was there any detected gender bias result in the overall test bias? Their method is they had 22,035 participants who were undergraduate students between 2008 and 2019. And it was the study was done at the university, and it was where they recruited undergraduate students and they got some credits for one of their classes for participating. The people that participated, 64.9% were women and 35.1% were men. And they used item response theory, more specifically differential item functioning over classical test theory. And so what they were trying to do was not only look at the overall test, but also look at each item to see if there was a difference in the way that that item was answered between men and women, and if there was anything that was interesting about how often those items were endorsed. And so the results were the MSBD provided reliable test findings, certain questions providing more information than others. And so the most commonly endorsed item in the full sample was impulsivity, and the least endorsed item was self-harm suicidality. Overall, women endorse every item more frequently than men. A total of 1,138, 5.2 participants endorsed 7 or more items and had a positive BPD screen. Of these participants, 831 were women and 301 were men. So that was 5.8% of the sample turned out to be positive for BPD on the screening, and 3.97% or 301 were men. And the interesting part about it, we continue on, the study sought to use IRT to evaluate several previously unknown characteristics of a frequently used screening measure, the MSI-BPD. And it suggested that these items are more helpful in identifying individuals likely to meet criteria, and that was specifically affective lability and chronic feelings of emptiness. And the results also seem to display bias toward women, affective instability, self-harm, suicidality, abandonment, while others displayed bias towards men at lower BPD severity levels, impulsivity and anger. When taken together, the overall effect size showed only a small difference between men and women, suggesting that the clinical significance of this effect is minor. So basically, what they were saying is that this test, it appears based on this research, that it can be used both for men and for women. It also really made clear, though, that screening measures should not be used in place of valid diagnostic tools for making a psychiatric diagnosis. So this is just one step in being able to screen people for BPD and potentially get them into treatment. However, it is not the only one. Also, that let me double check. And so one of the things too, some of the screening questions in the McLean might also show up in characteristics that are considered to be more masculine and more feminine. One of them being the report of anger might show up more with men than with women, simply because there is more of a societal expectation that men have the emotion of anger, while women are often not presenting with that anger, and sometimes it shows up as sadness. And the next study, the limitations of this study is that the age of the sample, that gender was being listed as binary as opposed to also encompassing other gender identities. The educational background of these participants were all college educated, and there's other demographic data that may impact the McLean screening inventory for borderline personality disorder. Contributions to practice. So for me, in my practice, I work predominantly with borderline personality disorder, narcissistic personality disorder, and antisocial personality disorder. So it's very important to me in my practice that I am screening when I'm supposed to be screening and diagnosing correctly. And so knowing whether or not this tool that I have access to can be used appropriately with my clients is something that's important to me. And am I measuring what I'm supposed to be measuring? Am I actually capturing what I need to be capturing? And this is important so that way we can appropriately screen and diagnose and get men into treatment. Because we know by the research that men and women, they meet criteria for BPD at roughly the same rates. However, men don't present, men don't get diagnosed, and men don't get treatment for this disorder at the same levels that women do. And so we need to figure out how to get them into treatment, how to get them diagnosed, etc., especially for me in my practice. It's really a big deal to me. So the next article that I have is, where are the men with borderline personality disorder? Where are they existing? What goes on? How can we get them before they get older and their symptoms get worse? And so the next article I have is Prison or Treatment: Gender, Racial, and Ethnic Inequalities and Mental Health Care Utilization and Criminal Justice History Among Incarcerated Persons with Borderline and Antisocial Personality Disorders. So what I thought was very interesting, I've worked myself in the prison system, and I absolutely adored working with my personality disordered inmates. And oftentimes they did have that co-occurring BPD with ASPD. And so I often noticed that they didn't get the diagnosis of BPD, although they would often get ASPD. And it was always interesting to me, this difference that showed up. And when I came across this article as I was doing a literature search for men in BPD, I thought that this was really applicable to me and the work that I would like to do. And so the research question of this article is, does gender, race, and ethnicity influence involvement with either mental health treatment or criminal justice system for people with co-occurring BPD and ASPD? And what is the role of externalizing and internalizing symptoms and the trajectory of client treatment? And are there potential gender differences between externalizing and internalizing symptoms? Now, this article is interesting in that it went across and took in a lot of information that for me wasn't really what I was interested in. So I'm just basically going over the parts that I am interested in with this article, and that has to do with gender. And so with this design, these individuals were gotten from another study. This was a study underneath of it where they basically got this group from individuals that were um, they were in the prison system already in a substance abuse program. And the individuals were chosen, and there were 310 of them with a lifetime history of borderline personality disorder and antisocial personality disorder. They were diagnosed using the structured clinical interview for personality disorders. Clearly, since they were incarcerated, they had a history of criminal justice involvement, but the study was looking at when that criminal justice involvement started to happen. And they also looked at their history of mental health care utilization. And the way that it was set up for the study is the inmates were interviewed with 2 sessions for a semi-structured interview with a different interviewer for each interview. And what they found is that they were regarding BPD symptoms. 68% of the participants reported a history of unstable relationships. 85% had reckless behavior. 57% had fears of abandonment, and 18% had histories of suicidal ideation and or attempts. And this is results for all, both the males and the females. Then, regarding the ASPD symptoms, 37% endorse a history of work instability, 94% a lack of remorse, and 79% had chronic lying, conning behavior. Most participants reported extensive histories of criminal justice involvement, including an average of 14.09 prior arrests and more than 5 years of total incarceration. Age of first arrest varied widely. Approximately half of first arrest occurred in adulthood. Approximately 64% reported having previously perceived the need for mental health services. 66% previously received mental health services, and 53% received psychiatric medication. Approximately 1 in 5 of the participants of the study reported a history of psychiatric hospitalization, consistent with common difficulties and co-occurring disorders associated with BPD and ASPD. 51% of participants reported a history of depressive symptoms, 51 anxiety symptoms, 8% had hallucinations, and 49% had cognitive difficulties, and 26% had difficulties controlling violent behaviors. Now, women were significantly more likely than men to endorse a history of fears of abandonment and suicide ideation or attempts. There was also, consistent with their hypothesis, women were more likely than men to have reported histories of perceiving a need for mental health care. Partially consistent with their hypothesis, results broadly suggested that incarcerated men, relative to women, with these personality disorders were more likely to have early extensive criminal justice involvement, whereas incarcerated women had more extensive mental health treatment histories. So basically, what that means is that young men, boys, they were more likely to be funneled into the criminal justice system when they have these diagnoses, as opposed to women who were more likely in the beginning to be funneled into the mental health care system. And also, incarcerated women relative to men with lifetime BPD and ASPD were also more likely to endorse a range of internalizing symptoms. So results underlie gender differences in histories of criminal justice involvement and mental health utilization, which persisted even after they controlled for key social determinants of health and despite similarities in symptom presentations. Findings are consistent with theorized barriers to care and systemic biases that preclude accessing mental health services and instead promote criminal justice involvement with men. So, The findings have direct implications for the treatment of BPD and ASPD in both the prison and in the community. Results imply that community mental health providers of men that they should be familiar with the range of difficulties that arise from being involved with the criminal justice system. And these include barriers to employment, housing, and relationships. Nevertheless, these considerations aren't often integrated into treatment. One of the things, too, that they talk about is that the traditional programs for DBT, which is an evidence-based intervention for BPD, often doesn't take into account the criminal justice aspect that often shows up for these individuals. The limitations of this study was that it was a modest sample size, unable to assess intersectional inequalities. So, like I said, this article also went into information regarding uh, race and ethnicity. For the purpose of this presentation, I focused more on the genders, and the data collection didn't also really go over the intersection, like white males versus white females versus um, Hispanic identifying males, Hispanic identifying females, that they didn't really go over those intersections. Also the data that was collected was from the mid 2000s, and it was collected from a substance abuse program. And there's also where because they looked at both of the diagnoses together, comorbid BPD and ASPD, does this really apply to either just BPD, these findings, or just ASPD? They would have to do another study to weed out the both of them. They didn't really go over why they did a comorbid. For me, it made sense given my history working in the prison system that often these two diagnoses were comorbid. That's just my experience as well. And I can imagine if they're using the prison environment, it's going to look like that. Contribution to practice. And so for me, once again, I want to get these individuals into treatment. When I had originally set up my practice, the intent was to provide services for people getting out of the prison system. Those individuals didn't really show up. Turns out I'm really, really good at working with people with borderline personality disorder. I'm really good with working with people with cluster B personality disorders. So the shift of my practice moved from people that were coming out of prison to people with BPD, ASPD, NPD. And now, for me personally, my practice has shifted more to adolescents and adolescents that are on the trajectory for incarceration, that meet criteria for conduct disorder, borderline personality disorder. And I work really, really hard at trying to keep them out of the prison system. This information right here really helps me to understand that the males that might present to me, it makes sense that they, for me, already have DJJ involvement. While the females that I work with, they tend to not. They tend to have started with me, even though they do have some criminal behaviors and do meet some of the criteria for conduct disorder, that I would be seeing them first before their involvement in corrections and the justice system. So that is how they contribute. This article contributes to my practice. I want to reach out to DJJ and get those males that are involved with the criminal justice system and meet criteria for BPD and conduct disorder. And there's also where there might need to be where I do some education for clinicians that are working with these individuals. I already do have a YouTube channel where I do informative videos for individuals that are working in the Department of Corrections. It might be helpful for me to do a video specifically for clinicians working in DJJ to get these individuals, and also probably do some videos for counselors in schools that see these individuals that have these externalizing behaviors, such as angry and aggressive outbursts, and get them into treatment with me and the other people in my practice, because we love our BPD and ASPD and our conduct disorder clients. And on to our next article. So the next article is Exploring the Pathways to Diagnosis for Men with Borderline Personality Disorder, a qualitative study. So with this article, they went ahead and, the research questions is what can we learn from the stories told by men diagnosed and treated for borderline personality disorders? How can we use this information to make our programs more receptive or pick up these individuals uh, long before they have these crisis points? And what can we learn? When do they believe symptoms began to emerge? When and why did they finally receive their BPD diagnosis? And what is the impact of diagnosis on the person with borderline personality disorder? So, the methodology for this one is the researchers sent out a little advertisement. They posted it on social media and they recruited 8 men, and the mean age was 45.9 years. It was a qualitative interview study. And they did a single interview, 60 to 90 minutes. It was semi-structured, and they used good old Zoom. The interviews were transcribed and analyzed using interpretive phenomenological analysis. And so what they found was participants reported that symptoms of BPD began during adolescence at an average age of 13 years old. This often seems to be an issue with clinicians, which I could do a whole other PowerPoint on. The evidence indicates quite clearly that we can diagnose BPD in adolescents quite reliably. And the sooner that we are able to get people into treatment, the better off they are. It tends to cut down on unnecessary medications, wrong diagnoses, and it gets them into either DBT, MBT, schema therapy, or transference focused therapy. And these are all evidence based practices for the treatment of BPD. And so, like I said, the study indicated that the average onset was 13 years of age, and the range was anywhere from 10 to 15. The clients, the interviewees in this study, they had noted that oftentimes that the way that they displayed their symptoms was more externalizing than internalizing. And they had these really big emotions that oftentimes showed up in angry outbursts, but they also showed up in the way of sadness and anxiety. And what that meant is that these individuals were often punished for their emotions. They were punished for being angry and aggressive, and they were shamed for having these other emotions that were considered weaker, such as sadness and anxiety. And they suffered, they suffered, they suffered. And then they wound up having what they would call a crisis point. And this crisis point would be a breakup that occurred, job loss, some sort of disruption, and the resulting collapse of themselves. And then they would show up for services. And they would often show up for services with their general practitioner. And the general practitioner would say, "Oh, you're depressed. Here's some medication." And they found that the medication wasn't very helpful. They found that it didn't really do much for them. And so for some of the individuals that were in this study, they found themselves avoiding mental health services because they didn't find that it was actually helpful for them. Their symptoms were dismissed, not really explored, and they also didn't have the emotional uh, information to be able to adequately explain their internal experience and what was going on. So they had this emotional illiteracy. And for some, they also wound up having these involuntary admissions. And these involuntary admissions, it only made them feel even worse about their involvement with the mental health system. So then they finally wound up getting their diagnosis. And the interesting part about them getting their diagnosis is it often happened during inpatient stays or getting a diagnosis through a private psychiatrist. They also would find out by these informal networks, these informal ways of resonating with a mental health diagnosis through social media. They would watch videos about somebody with BPD, and it was like a light went off. It was like they said, "Oh my goodness, this explains so much about my experience." And then they would go and pursue that diagnosis. And then with that diagnosis, they also then went and was able to pursue treatment. And they often found themselves feeling very um, uh, hurt that it took so long for them to get the diagnosis and to get the correct treatment. Now, the limitations for this was that there was a small sample size. They were self-referred for the study. And once again, there's this binary concept of gender. So it didn't allow for these more nuanced expressions outside of the dichotomy of either male or female. And what also was interesting to me with all these studies, oh, in the contribution to practice. So once again, what I really appreciated about this study is very similar to the last study, is it's being able to identify adolescent boys that are showing symptoms of BPD and understanding that they might show up more of those externalizing symptoms of BPD as opposed to those internalizing. And based on the study, where might I go find referrals? Where might I go figure out where to grab a hold of these individuals so they don't have to suffer as long, that they don't have to go. And I believe with this study, it wasn't until they were in their 40s that they were finally diagnosed. So I believe that there was a gap of about, I want to say, just give me a moment. But there was, I think it was something about 32 years between the onset of their symptoms. 22 years. Despite experiencing considerable distress and dysfunction, it took an average of 22 years after symptom onset to receive a diagnosis of BPD. The average age of diagnosis was 36 years. This is substantially longer than what is reported by women with BPD, which was closer to 15 years. Now, both these to me is kind of ridiculous judgment, and I'm going to own it, that it takes 15 years from onset of symptoms for women to be diagnosed with BPD and 22 years between onset of symptoms and that receiving a diagnosis of BPD. That means all these years of just suffering for no reason, to me, no good reason. So knowing this, knowing that we need to look out for this diagnosis so that way people can get appropriate treatment, I think is going to contribute to my practice. I need to make sure that I'm catching these individuals. And I also need to be aware of the difference between how males and females present with BPD. Now, one of the things that I have found interesting in all my readings is that males tend to not, and this is my reflection, it's been my experience that males tend to present with a different way of experiencing this fear of abandonment and fear of rejection. And that shows up in the literature, that they don't endorse that symptom so often. I think that they endorse it in a way that is different than the way that it is conceptualized in the diagnostic criteria. It's been my experience that a lot of the men, it shows up as experiences of jealousy and fear that their partner is going to cheat on them. So, as opposed to this fear that their partner is going to leave them, reject them, or abandon them, their form of rejection or abandonment is that their partner is going to cheat on them. And this jealousy and this controlling behavior shows up for them. Now, it's been my experience working with women and girls that this fear of abandonment also shows up in their friendships. And I also perceive, having observed the difference about the way men and women are socialized in their relationships, men and boys are not socialized to have close emotional relationships with their same sex peers. It seems to be that men have closer, more emotionally vulnerable relationships with their romantic partners, not their friends. So the fear of abandonment doesn't show up with their male relationships, their male friendships, like they would show up with women and girls and their relationships. And so I think that that also needs to be looked at a little bit different when we're looking at how the McLean is screened, because it even said it in that study that men endorse this fear of abandonment, fear of rejection less than women do. And I think it's just that they don't have the language, because when I've gone down deep with the individuals that um, have this jealousy and this controlling, it really comes down to them being afraid of that abandonment and that rejection. Um, and for the final future research, I really want to get a firmer handle on that piece of information, the fear of abandonment, fear of rejection, that does it show up as jealousy? Can it just be conceptualized as different? The other thing that they often talked about a difference in men and women endorsing is that feeling of emptiness. And once again, having worked with both males with BPD and females with BPD, I believe that their conception of the feeling of internal emptiness, I think it just is expressed differently with them. Because when you ask the questions in the right way, the experience is similar. It just has different terminology. Um, and this is my presentation for the critique. For a brief recap, it was 3 different articles. The first was the assessment using the McLean screening instrument for BPD and the impact of gender, if there is an impact on it. The second article was the prisoner treatment, understanding the role of gender in BPD and ASPD, whether people are funneled into the criminal justice system or funneled into the mental health treatment. And lo and behold, surprise, surprise, men, boys are funneled into criminal justice system, and it appears that's because of the more externalizing and aggressive behaviors. Well, women, because of their more internalizing and self-harming and suicidal behaviors, they tend to be more pushed into the mental health trajectory, the mental health path first. And then in the final article, it was exploring the pathways to diagnosis for men with borderline personality disorder. I hope that you found this presentation helpful. I feel like the need to say, as I do these videos for my YouTube channel, please like and subscribe. Just joking. I hope you found this helpful. Thanks.